So it's a really important question to ask. Get a feel for what are the key things that you'd like to address or change. And then the other thing in insight is, do you foresee any barriers to the treatment? That's really what I'm thinking about. And what are the barriers that come up? I want to identify personal barriers. So this could be things like attitudes to medication. What do they think about medication? How long do they think they need to take it for? So now let's look at what an assessment, an hour's assessment looks like. And this, of course, we know as part of the exam as well. For example, the long case in Australia had, an hour. You often sort of finished it around 50 minutes. You then thought and wrote down the formulation. So this is a sort of structure, but this is exactly what happens in the private setting as well. You just have more time if you want to. You're a lot more flexible. But the principles remain. So the first part, which is 20-25 minutes in a way, is you are searching or you are thinking about what sort of spectra apply to this patient. And we'll see what I mean by spectra, because we will be using a diagnostic hierarchy. And that involves, are there organic aspects here? So that's the organic spectra. The neurodevelopmental aspects also are sort of in that organic bit. Next level, is there a substance use type paradigm I need to apply? What about medications? Is it possible that there is a medication-induced condition? Next layer, I'm thinking about the bipolar spectrum or the psychotic spectrum. Next layer down, I'm thinking about the depressive spectrum. And we'll see the depressive spectrum is very much about thinking whether activity, cognition, or emotion are involved, all three, or just one dimension around the emotional, milder end of the spectrum. We'll be delving deeper into this. Next layer, I'm thinking about OCD and eating disorder and trauma, past a significant life-threatening event and current stresses. And I'm also looking at anxiety. And then finally, the personality organization of the individual. So my first 20 minutes, depending on the case, I'm not going through every single one usually, because often when there's an acute condition, there's agitation, you often can't really go into the personality structure at that point. They're too distressed. So we start working on the higher levels. So we come up with a diagnostic spectra understanding, and this might be the individual spans the affective spectra or the bipolar spectra and the psychotic spectra. There are organic factors, X, Y, Z, present. So now you're getting a range of sort of diagnostic aspects for this individual. And 20 minutes is sufficient to get a feel for that. Now, once you get that feel, you will then move towards the understanding of why now, the 10 to 15 minutes. And this is where you hone into the formulatory aspects. So now I will look at extracting information from the past history, the past medical history, the family history, personal history, and depending on what I identified, for example, if they've got a movement disorder that they presented to me with, I will be honing into the family history. I will want to ask about whether there is a family history movement disorder, because if there is, and they say, yeah, my father, my grandfather, both seem to have a similar sort of presentation. It happens in restless leg syndrome. We know certain autosomal dominant conditions. You see, that takes me down a certain trajectory. Similarly, if they've talked to, if there's a trauma-related aspect that's present, a post-traumatic stress disorder construct, then here I will be looking at the attachment aspects, and I will backtrack to see whether there is the attachment model and what's happened, so that I can link it to the current formulatory aspects. So that, you see, these aspects, these two aspects will help me develop that formulation. So I'll be looking at biological factors, I'll be looking at the psychological factors, and we'll break it down. We'll see exactly what are the factors we'll look at. And once we identify, we will create narratives, right? So the formulation, but then I've got about 3 to 5 minutes. So often what happens here is you can take a minute or two to really think. I do that very commonly with patients. I say, I just need a couple of minutes to think, to make sure I've not forgotten anything, or do you think I've forgotten something relevant, right? Because remember, it's a doctor-patient relationship. Gathering information requires, letting them know that whatever they think is relevant, please let me know. I'll integrate that and see or identify its relevance. Because sometimes patients think, oh, I didn't think that was relevant when it could be, right? So I want to find out whether there's missing gaps in this. And of course, this is where we're looking at the mental state examination. If I've missed, for example, I might say, okay, you're on an antipsychotic medication. I want to examine you. I want to carry out a frontal lobe luria 3-step examination because you've mentioned, there's movement disorders there, and you mentioned a family history. So depending on that, I can then hone into physical, cognitive examination, etc. That's here as well. So you've got, the MSE and the cognitive and physical examination, or eating disorders. In eating disorders, you're most certainly going to look at that because it's linked to risk. It's linked to you need to decide whether they need a medical admission or not at that particular point. And then we come to the insight and needs assessment. So towards the end, what we're really looking at in the insight is, of course, we know that often the common questions are, what do you think is going on? Do you think you have an illness? Adherence to medication, etc. But what we want is a lot more nuance. So one of the things that I ask patients, and particularly in the initial phases, and it's part of that outcome assessment that we saw at the start. So I say, is that thank you for giving me a good understanding of what's going on. If there were 3 things that you'd like me to start working on at this point in time, what would they be? What would be the 3 most important things you'd like me to address? And it's very, very valuable. But what's surprising is that often it may be quite different from what you've planned, because our thinking is often from a clinical perspective, from a diagnostic perspective. But they might highlight things like, my partner doesn't understand what's going on for me, right? I just need a couple of nights good sleep. And you see, matching that with your clinical outcome enhances the therapeutic relationship, because I can provide a good night's sleep. I can arrange a meeting in a couple of weeks to speak to their partner, for example, which may remove a certain stressor as well. So it's a really important question to ask towards the end. Get a feel for what are the key things that you'd like them or they'd like you to address or change. And then the other thing in insight is, do you foresee any barriers to the treatment? That's really what I'm thinking about. And what are the barriers that come up? I want to identify personal barriers. So this could be things like attitudes to medication. What do they think about medication? How long do they think they need to take it for? How does their family think about medication? What are the family's attitudes to medication? Are there any cultural aspects related to the medication that's prescribed or to the psychotherapy that's implemented? What do they think of it? Do they think it's working? Right? So these nuances really help you, because you'll be surprised when you go into these details, is that sometimes there are lots of assumptions that can be very easily clarified. But also, it's in these outcome assessments that you get a lot of ingredients for psychotherapy. So I find it extremely, extremely valuable to really get an understanding of their expectations about what are the key domains that they really want to target or change. And I use the word target. So personal factors, medication factors, I know the illness factors that might be playing a part, and any system factors, because sometimes, I have to travel so much, doctor, or this medication costs so much, I can't afford it. So now you see I've got a better understanding of the insight and the barriers that I want to include in my treatment. So now you can see, take a step back, think about your hours interview next time, and the diagnostic spectrum, I'll show you the hierarchy. You can even sit down with the patient and use the diagnostic hierarchy. Very, very valuable. Then hone into the different domains of personal history and medical history, etc., and extract the relevant information. This will help you build that formulation at the end of the hour when you dictate it. Then ask yourself, do I need to do anything specific in the mental state examination? Have I missed out something? Do I need to ask about racing thoughts? Or they've told me about the worry. Is this a worry or as part of preoccupation? Or is this more a rumination? And I can ask those questions and we'll see those. Cognitive physical examination, and then finally the insight and needs assessment.